Welcome to our series. In this video, we are going to cover the knee joint anatomy and biomechanics. So, the knee is the largest and one of the most complex joints in the human body. It connects the femur to the tibia, with the patella sitting anteriorly and fibula positioned laterally. Although the knee is primarily designed for flexion and extension, it also allows a small amount of rotation, particularly when the knee is flexed. Its stability depends on the combined contribution of bones, menisci, ligaments, muscles, and the joint capsule. In this video, we'll build the knee from ground up, starting with its anatomy, then moving into biomechanics, and finally the most important clinical correlations. Let's begin with the bones. From the anterior view, we can identify four major bony structures: the femur, tibia, patella, and fibula. The distal femur forms the superior part of the knee joint. The proximal tibia forms the inferior part. Anteriorly, the patella articulates with the femur to form the patellofemoral joint, and laterally, the fibula provides attachment for several important structures, although it does not directly participate in the tibiofemoral articulation. Now, let's look more closely at the distal femur. The medial and lateral femoral condyles form the main articular surfaces for the tibia. Above them are the medial and lateral epicondyles, which provide attachment sites for important ligaments and muscles. Anteriorly, we have the patellar surface where the patella glides during knee movement. Posteriorly, the condyles are separated by the intercondylar fossa. This region is particularly important because the cruciate ligaments attach within the intercondylar region. Moving to the proximal tibia, we find the medial and lateral tibial condyles. Together they form the tibial plateau. Between them is the intercondylar eminence, which provides attachment for the cruciate ligaments and menisci. Anteriorly, the tibial tuberosity provides attachment for the patellar ligament. Laterally, we find the fibular head, which is an important attachment site for the lateral collateral ligament and other posterolateral structures. The patella is a sesamoid bone embedded within the quadriceps mechanism. Its anterior surface is relatively rough, while its posterior surface is covered by the articular cartilage. Posteriorly, the patella has medial and lateral articular facets that articulate with the femoral trochlea. The base is superior and the apex points inferiorly towards the tibial tuberosity. The patella increases the mechanical advantage of the quadriceps and helps transmit forces across the knee. The knee can be considered as two major articulations. First, the tibiofemoral joint between the femur and tibia. Second, the patellofemoral joint between the patella and femur. These articulations work together to produce efficient movement while maintaining stability during weight bearing. Now we come to one of the most important structures of the knee, the menisci. There are two, the medial and lateral menisci. They sit between the femoral condyles and tibial plateau. From above, the medial meniscus has a more C-shaped appearance, while the lateral meniscus is more circular. Their primary role is to improve the congruence between the femur and tibia, but they do much more than that. They help distribute load, absorb shock, contribute to stability, assist lubrication, and provide proprioceptive information. Each meniscus has anterior horn and posterior horn. Its peripheral border is attached to the joint capsule. The menisci are therefore relatively fixed structures, but they need to move during knee motion. The transverse ligament also connects the anterior portion of the medial and lateral menisci. The medial meniscus is generally less mobile because of its stronger attachment to the capsule and its relationship with the medial collateral ligament. The lateral meniscus is more mobile and is separated from the lateral collateral ligament by the Popliteus tendon. The difference in mobility is clinically important. The relatively reduced mobility of the medial meniscus makes it more vulnerable to injury, particularly during twisting movements. The medial meniscus has a close relationship with the MCL. The lateral meniscus, on the other hand, has an important relationship with the Popliteus tendon. These relationships become particularly relevant when understanding combined ligament and meniscal injuries. Think of the menisci as the knee's load management system. They distribute comprehensive forces over a large surface area. They absorb shock, they improve joint congruence, contribute to stability, assist in lubrication and proprioception. So, when meniscal tissue is damaged, the consequences extend beyond simply causing pain. The mechanics of the entire joint can be affected. Now, let's move to the major ligaments. The four key ligaments are the ACL, PCL, MCL, and LCL. The ACL and PCL are the cruciate ligaments. MCL and LCL are the collateral ligaments. Together, they control excessive translation and rotation while guiding normal knee motion. The anterior cruciate ligament runs from anterior region of the tibia towards the lateral aspect of the femur. Its major function is to resist excessive anterior translation of the tibia relative to the femur. It also contributes significantly to rotational stability. The ACL can be divided into anteromedial and posterolateral bundles. Their tension changes depends on the position of the knee. The posterior cruciate ligament runs from posterior tibia towards the femur. Its primary role is to resist posterior translation of the tibia. When comparing the two, the ACL primarily prevents the tibia from moving far too forward. The PCL primarily prevents the tibia from moving too far backwards, but both also contribute to rotational stability and guide the arthrokinematics of the knee. The medial collateral ligament resists valgus stress. The lateral collateral ligament resists varus stress. The MCL has close relationship with the medial meniscus. The LCL attaches to the fibular head and forms part of the lateral and posterolateral stabilizing structures. The posterolateral corner is more complex stabilizing region. Important structures include the LCL, Popliteus, Popliteofibular structures, and the contribution of the biceps femoris. These structures work together to control varus and rotational forces. A simple way to remember the major ligaments is ACL prevents excessive anterior tibial translation, PCL prevents excessive posterior tibial translation, MCL resists valgus stress, LCL resists varus stress. Surrounding the knee is the joint capsule. The outer fibrous layer provides mechanical support. Deep to it is the synovial membrane, which lines the non articular portions of the joint. The synovial membrane produces synovial fluid, helping reduce friction and nourish the articular surfaces. Anteriorly, the synovial cavity extends into the suprapatellar pouch. The knee also contains several bursa. Important examples include the suprapatellar, prepatellar, infrapatellar, and pes and serai bursae. These fluid-filled structures reduce friction between tissues during movement. Clinically, inflammation of this bursae can produce localized pain and swelling. Now let's look at the muscular system. The quadriceps form the major knee extensor. Hamstrings are important knee flexors. Other muscles contribute to rotation, stability, and control. The key muscles we'll focus on are the quadriceps, hamstrings, sartorius, gracilis, gastrocnemius, and popliteus. The quadriceps consists of rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius. Together, they extend the knee. Their force is transmitted through the quadriceps tendon to the patella, then through the patellar ligament to the tibial tuberosity. The main hamstrings are biceps femoris, semitendinosus, and semimembranosus, all of which contribute to knee flexion. The biceps femoris also contributes to lateral rotation of the tibia when knee is flexed. The semitendinosus and membranosus contribute to medial rotation. Several other muscles contribute to knee function. Sartorius assists flexion and medial rotation. Gracilis assists flexion and medial rotation. Gastrocnemius contributes to knee flexion. And Popliteus plays a particularly important role in initiating knee flexion by unlocking the knee. On the medial side of the proximal tibia, the tendons of three muscles come together to form the pes and serenus. These are sartorius, gracilis, and semitendinosus. The common insertion is located on the anterior medial proximal tibia. The knee receives articular branches from several nerves. Important contributions include the femoral, tibial, and common fibular nerves, with additional contributions from the obturator nerve. These articular branches provide sensory information from the joint and contribute to the proprioception and pain perception. The knee has an extensive arterial network. Branches from the popliteal artery, particularly the genicular arteries, form an anastomotic network around the joint. There are also contributions from descending genicular and recurrent branches. This vascular network helps maintain blood supply around the knee, particularly during movements. The primary movement of the knee is flexion and extension. The knee also permits medial and lateral rotation, especially when flexed. Typical knee motion ranges from approximately 0 degrees of extension to around 135 degrees of flexion. All the normal values vary between individuals. The end feel also changes with movement. During flexion, the end feel is generally soft because of tissue approximation. During extension, the end feel is firmer because of capsule and ligament. In open chain movement, the tibia moves relative to the femur. In a closed chain movement, the foot is fixed and the femur moves relative to tibia. These distinctions become particularly important when discussing the screw home mechanism. Now we reach one of the most important concepts in knee biomechanics. During the final approximately 20 to 30 degrees of knee extension, the knee undergoes a rotational movement known as the screw home mechanism. In open chain, the tibia externally rotates relative to femur. In closed chain, the femur internally rotates relative to the tibia. This rotation helps lock the knee into its most stable position during terminal extension. Several factors contribute: the asymmetrical shape of the femoral condyles, the tension within the ligaments, movement of the menisci, and the geometry of the tibial plateau. Together, these factors create the terminal rotation that increases stability in full extension. But how does the knee get out of this locked position? The popliteus. At the beginning of the knee flexion, the popliteus helps unlock the knee. In open chain, it internally rotates the tibia. In closed chain, it contributes to internal rotation of the femur. For the exam, remember open chain terminal extension, tibial external rotation. Closed chain terminal extension, femoral internal rotation. Closed pack position, full extension. Loose pack position, approximately 25 to 30 degrees of flexion. Unlocking mechanism, popliteus. Now let's apply the anatomy clinically. ACL injuries commonly occur during pivoting, sudden deceleration, or changes of direction. A combination of valgus stress and rotation can place substantial strain on the ACL. Hyperextension can also contribute. The result may be excessive anterior translation and rotational instability of the tibia. ACL injuries may occur together with injury to other structures. The MCL and menisci can also be involved. The classic unhappy triad is often taught as ACL, MCL, and medial meniscus injury. However, this is an oversimplification of the range of injury patterns seen clinically. The key concept is that high energy rotational forces can damage multiple stabilizing structures at the same time. A classic mechanism of PCL injury is a posteriorly directed force applied to the tibia while knee is flexed. The commonly described is dashboard mechanism. The force drives the tibia posteriorly relative to the femur, stressing the PCL. Meniscal injuries commonly occur when the knee is loaded and simultaneously twisted. The meniscus can become compressed between the femur and tibia. Because the medial meniscus is less mobile, it is particularly vulnerable during certain twisting mechanism. The patellofemoral joint is formed between patella and femoral trochlea. The quadriceps generate force through the patella and patellar tendon. As the knee flexion increases, patellofemoral joint loading increases also. This is why activities such as squatting, stair climbing, and running can place significant demands on the patellofemoral joint. Finally, let's look at osteoarthritis. In a healthy knee, smooth articular cartilage allows the femur and tibia to move with minimal friction. With osteoarthritis, cartilage progressively degenerates. This can lead to joint space narrowing, osteophyte formation, and changes in the subchondral bone. Think of the progression as normal joint, cartilage degeneration, reduced joint space, osteophyte formation, and then progressive mechanical dysfunction. Finally, we have high yield points which you need to remember in the slide. You can take a screenshot which will help you for the last minute revision before exam. And you have this final biomechanics review and the final takeaway. If you understand the anatomy, you can understand the biomechanics. Understanding how these structures work together is far more useful than memorizing them individually. Now, if you understand the biomechanics, clinical injuries will start to make sense. That's the knee. If you like the video, please like, subscribe, and share.